Hello, everyone. Morning.
Morning, everyone. I think it's just us, but good
It
morning
is.
to anyone who's going to watch this in recording.
So it is crunch time for anyone who's watching. You've got exams coming up, and that's the whole purpose of us creating this program to help you with like quick revision and everything. We're starting off with dermatology, which I find really dull. So maybe we can make it exciting for you.
Hopefully.
Let me just full screen.
Awesome.
Sam, you can go ahead whenever you're ready.
Yeah, perfect. So this is dermatology. It's the lovely slides were made by Rupali, and then I'm going to present it as well. It's most of what you guys need to know for your exam. Next slide, please. All the topics that are in bold are the ones that are included in this presentation. The ones that aren't, so the skin disorders in children and in pregnancy, they're going to be incorporated in the other ones, I believe, from what Rapali told me. So in the
Yes.
obs and gynae and then the pediatric ones.
Yes.
So
I'm
it
going to
doesn't mean
try
that.
to include it in that, or I will add it to this presentation because that doesn't
Okay.
really require a lot of like explanation.
Oh, we have a student.
Yeah, hello. Hi. We've started a little bit. We were just talking about how we're going to cover the high yields topic. So everything that you see on your screen in bold is what we're going to cover. Everything that's not in bold, so skin disorder in pregnancy and children, I believe doesn't require a lot of explanation. So I'm going to add it to the presentation anyways, but we're not going to cover it in this video, otherwise it'll become really long. Is that okay?
Yeah, that's fine.
Cool. Clem, you can
And
go ahead.
also, past medicine has some really good, in the book of past medicine, it's got some really good pictures and like differentiations between all of those skin disorders in children, mainly the ones in pregnancy, which I always kind of struggled with. They've got some really nice pictures and explanations. So I would recommend checking that if you feel like you need more explanation from the slides. So Rupali is going to add on to that.
Okay, yeah, thank you.
Awesome. Perfect. So next slide, please. So first topic is acne vulgaris. So we all know it as just acne, which is mainly present in teenagers, but also adults will present with it. So it's the obstruction of the pilosebus follicle, with keratin plugs. And that means that you have kind of inflammations. You can have pustules. Oop, pub is coming in.
You've got another one?
We've got someone else.
I'm so
Morning,
happy.
pub.
Hello. Sorry to
It's
interrupt.
fine. You don't need to talk. It's okay. So we just started pub where it's just the first topic. You can review the first few minutes if you need to. So the way it's going to present on someone's face, the clinical presentation, sorry. Oh my goodness.
Hello, welcome to to everyone who's joined in now. We've sort of covered what are the high yield topics, and you can review it in the recording. So we're just on the first one at the moment, and Clem's taking over.
Yeah. So I'm just going to restart. The way it presents is going to be the pathophysiology, is the obstruction of the pilosebus follicles with keratin plugs, which causes those closed kind of comedones, which will present as like white or black heads. They can also be quite inflamed, so you're going to have erythema. You can have cysts, you can have sort of nodular presentations, and then you can also have the pustules, which they're all demonstrated really well on the 6 pictures down there. So you have the different kinds of classification, sorry. So you have mild, which is mainly open and closed comedones. Then you have moderate, which is comedones plus papules plus pustules as well. Sorry. And then you have the severe one, which is extensive inflammatory lesions, which may include nodules, pitting, and scarring, which is kind of all of those put together, as well as the bottom one. So you're going to have extensive scarring, even though there's no active inflammation at that point. The moment where you have to do a referral according to the NICE guidelines is acne conglobata, menin extensive inflammatory papules, supportive cysts, and nodules as well, and that requires a dermatology referral. And then acne fulminans, which is a lot more severe, and you have more systemic features as well. This means that the person does need to be admitted and needs extensive treatment. Okay. Thank you. So the management for mild to moderate is usually a topical course of 12 that lasts 12 weeks. So you're going to have a retinoid paired up with a benzoyl. I'm so sorry, 1 second. Oh, no, never mind. Sorry, there was some noise. So a retinoid paired up with a benzoyl peroxide. You can also have a different kind of retinoid with clindamycin, or you can have benzoyl peroxide with clindamycin. For moderate to severe, it's topical plus an oral course of 12 weeks. So you've got a topical retinoid with benzoyl peroxide. You can have the same plus, apologies for that, a topical retinoid benzoyl peroxide plus an antibiotic, or simply just a topical retinoid plus an oral antibiotic. Sorry. Someone's making noise in my place. And then the oral antibiotics, so you don't necessarily need to always choose clindamycin. You can also have different kind of tetracycline, so limacycline and doxycycline, or you can also go for a trimethoprim or even a macrolide, so erythromycin, if the others are all contraindicated. Topical retinoids and oral tetracycline are contraindicated in pregnancy or when you're planning pregnancy. So you definitely need to make sure that these are not the cases for the patient that you're prescribing retinoid, whether topical or oral. And then oral retinoid is anyways only being able to be prescribed by a dermatologist.
Just to add something, oral antibiotics are not given by themselves. They're always given in combination with the retinoid and the benzoyl peroxide. So it all works together to help clear up the acne. And the important bit are things you're going to get questions on. So when you do get an MCQ, keep an eye out for, do they say that she's pregnant? Do they say that she's planning to get pregnant? Is she on contraceptives? So all of that is really important.
Okay, next topic is eczema, which is something that you'll probably see a lot, probably more in peds, I would say. So pathophysiology, it's a chronic inflammatory skin condition. There are moments of flares and flare-ups and then moments of remission. Triggers can be everything and anything, but the most common ones are like irritants, allergens, milk. As someone who's got eczema themselves, anything can trigger, whether it's the weather, whether it's something you've eaten, whether it's a new cream that's meant to have no additional perfumes or anything, like anything can be a trigger for eczema, and stress as well. So it's not only contact things. The clinical presentation is red, itchy, dry skin. It's always mainly in the flexures. You can have some thickening and lichenification. That's mainly when you've got more chronic plaques that have been there for quite some time and that are not really going away. And you can also have some super added infections on top of that, which could probably be in kids. It could be related to like impetigo, so Staph aureus kind of infections as well. Oh, Christabel's joining. Morning, Christabel. We've just started. We already covered acne and we're just on eczema at the moment, but this is being recorded, so you can always go back to the recording. Okay. The management for eczema is emollient, so keeping the skin moistured, ensuring that the skin barrier is very kind of oily and just always moisturized helps a lot. You can also use some antiseptics such as Dermol, and then using steroids, so they're put in the order of potency, so hydrocortisone the least potent, and then Dermovate the most potent. You can buy hydrocortisone over the counter for the patients. And that's going to be approximately 1% hydrocortisone. If they require stronger steroids, they would probably require to get a prescription from their GP. And then the rest of the management is more down the line, and that would be more specialist kind of prescriptions. So topical calcineurin inhibitors, tacrolimus, which is again by dermatology, as mentioned. Antihistamines are really good for stopping the kind of like itching overnight and everything when it's bothering someone to sleep or just in their day-to-day lives. And then dressings and dry bandages soaked in emollients to make sure that the dryness is not affecting you and not causing the kind of itchy symptoms. Next, please. Amazing. So next on is psoriasis. So it's also a chronic inflammatory skin condition, but this time it's immune mediated. Different triggers could be UV light, streptococcal infections, trauma, very much medication related as well. It can also present with other kinds of diseases, so pathology, sorry, so psoriatic arthritis. It can also be presenting with Crohn's, lymphoma. It increases the cardiovascular risk and increases HLA-B27 expression. The clinical features, so you've got the plaques, which are very like silver and scaly in color. The opposite to eczema is that it's on the extensor surfaces. Sometimes in question stems, it can be confusing, kind of differentiating the two if you're not sure about the different appearances, but the location will help you a lot. And then you've got the buttate, which is the raindrop, and that can also be related, if I'm not wrong, post-viral infection.
Mhm.
So the management related with the GP would be emollients and moisturizers again, so very similar to eczema. So so make sure you understand the differences between the two diseases, and then the vitamin D analogs such as calcipotriol, and then you've also got some topical steroids, and it's usually a combination where you put one in the morning, one in the evening, if I'm not mistaken, and you do that for a couple of weeks, I believe 4 to 8 weeks, and then you check, and if that's not useful, then you add the number of times you put one of them. And then the management for severe psoriasis would be coal tar, phototherapy, calcineurin inhibitors, again, like tacrolimus, and then a bit more severe, extensive medication is methotrexate, cyclosporin, and then TNF-alpha inhibitors such as infliximab and etanercept.
So if I just simplify it, in any inflammatory condition or an autoimmune condition, you're going to give a steroid because you want to suppress the immune system. So if you understand the pathology, the management is linked. And then if the steroids don't work, then you move on to actual immunosuppressant, which are basically your TNF-alpha inhibitors, your calcineurin inhibitors. So which is why I've put a little bit more pathophysiology than you need to know, because it explains the management.
Okay, awesome. So next is pityriasis versicolor or tinea versicolor or tinea corporis as well, which will tell you the location of it. So the pathophysiology, sorry, is fungal infection, which is caused by Malassezia for yeast. It's very common in the summer, especially, and people will notice it because they get a bit of a tan, and then they've got that discoloration color that you can see for the clinical features on the right. So you've got hypo or hyper pigmentation. The macules can be oval, round, they can be kind of scattered independently, or they can kind of fuse and cause like larger areas of pigmentation, and mainly on the upper trunk, back, and arms. The management, which is GP related, it's ketoconazole, so you need an antifungal medication. The shampoo is really good because you can just kind of use it for like in the bath and in the shower, and it should quite quickly clear it up. Then you've got selenium sulfide shampoo, which is used for 7 days as well. And if required, then you can go to an oral antifungal, which would be itraconazole. The important thing is that, like I mentioned, the summer, it's very common going out and kind of just catching it anywhere, or just noticing it more in the summer, basically.
Yeah, they'll give you it. They'll give you that in the questions. Someone went to Spain and he came back
Now
with
they've
a
got,
rash.
yeah, pigmentation all over their back.
Yeah.
But yeah, it doesn't tend to be itchy, so, but it can be.
Yeah, they just notice the pigmentation. It's more of a cosmetic thing.
Yeah, sorry, I said tinea versicolor and then it's the same as tinea corporis, but corporis is going to be different. Sorry about that.
Yeah.
The corporis is going to be itchy and it's going to be very solitary lesions, whereas this is more combined. Sorry, mistake on my behalf. Pityriasis rosacea is very much self-limiting. The way it presents is usually as a herald patch, which is a first initial patch, usually on the upper trunk, and then you've got more lesions that come in. So in this case, the hypothetical herald patch would be the bigger patch, and then you've got the smaller ones that come in a few days later. And they kind of describe it as pink salmon oval lesions. There's no treatment, it's just self-limiting. And as mentioned here, the important thing is that if it's in a pregnant woman, then you need to speak to the obs and gynae team just to make sure that nothing needs to be done or any sort of follow-up. Oh, Nalan. Yeah. Hi, Nalan. We just started, so the recording is going to be up, so you can just check out what we've already mentioned, if that's okay. So yeah. So pityriasis alba, it's mild dermatitis in children. The way it presents is a hypopigmented lesion on the face in dark-skinned children. So you can see it on the right corner of the mouth. It doesn't look very obvious, but you can see it. And it's usually just managed with some moisturizers. And the important point is that it should settle on its own after some time.
So I had this growing up. I think I still do. It's also
Really?
yeah, yeah. I've got like these white patches, and we could never figure out why I have them. There is a little bit of a link between vitamin D deficiency and pityriasis alba, but it doesn't really help because I took vitamin D supplementation and it didn't go
It
away.
didn't go away.
No, it didn't work.
Fine. Okay, next one, please. Perfect. So lichen planus, they love that in questions. You probably heard of it quite a bit on past medicine questions. So the pathophysiology is unknown, but it could also be related to, it could be drug-induced, sorry. So gold, quinine, and thiazides as well. The easy way to remember the clinical features is they all start with a P. So it's pruritic, so it's really itchy. Polygonal, so it's got many kind of sharp angles, which you can see on the picture. It shows it really well. It's planar, so the top of the lesion is flat. It's not going to be like bumpy or anything. It is raised because you can see it, but it's a flat kind of lesion. The papules are purple. And you can kind of see that there as well, pinky purple, and then they're plaques, like mentioned, so they're raised and discolored patches as well. Other clinical features, you can see the white little lines, which are called Wickham's striae. And then something called Cobner phenomenon is that new skin lesions can appear at the site of trauma. And I believe psoriasis also experiences Cobner phenomenon, so keep that in mind as well. The oral involvement, again, you're going to have white lace pattern-like on the buccal mucosa, so make sure you know the differences between that and like leukoplakia or oral candidiasis, because it could probably be a combination of those answers to kind of throw you off. So just make sure you remember the presentation and the 5 Ps. The management is just topical potent steroids. If it's going to be in the oral mucosa, then you need a mouthwash. And if it's quite an extensive presentation, then you might need oral steroids or immunosuppression, which again would probably be more dermatology specialist referral at that point. This one I absolutely hated as a med student, and on questions I still confuse them, so it's an important one to know. It's bullous pemphigoid. It's an autoimmune disease, and it affects the subepidermal layer, causing those blisterings with fluid-filled blisters, basically. From the picture you can see. The clinical features is, again, blistering, deep and tense. They're going to be quite itchy as well. The mucosa is not involved, which is the difference between the other one, which I don't remember the name. Nikolsky negative, which I believe is,
So it's when Nikolsky negative means when you try to move the skin, it like moves away. So the skin is so damaged that if you touch it, it disintegrates. So that's Nikolsky positive. You don't have that in bullous pemphigoid.
Which is present in the other kind of
Yes.
pemphigoid
more
disease.
extensive, severe, emergent skin conditions where there's so much damage. The skin is literally just falling off when you touch it.
Yeah. So investigations would be a biopsy because it shows you which layer is affected, as well as which kind of components of the skin are causing it. You can see that because it's an autoimmune disease. The management would be, again, topical steroids, and if it was quite a severe infection, it would be oral steroids. Bullous pemphigus, which is the one I forgot the name of, is also autoimmune, but it's intraepidermal rather than subepidermal. The clinical features, again, are blistering, but this time they're a lot more superficial and flaccid. The mucosa can be involved. So those two bold things, the Nikolsky positive and the mucosa involvement, is the difference when getting a question which has both of these answers, the pemphigoid and the bullous pemphigus one. Investigation. So again, it's Nikolsky positive, and again, you would do a biopsy to investigate further. And then the management is not topical this time; it's just systemic steroids. Awesome. So next we've got Stevens-Johnson syndrome, which happens in less than 10% of cases, and then you've got the toxic epidermal.
The less than 10% is the area of skin involved. So the difference
area
between
of skin involved. Fine.
Stevens-Johnson and toxic epidermal necrolysis is that 30% of the skin is involved. In Stevens-Johnson's, less than 10% is involved.
Awesome. The pathophysiology, so it's drug induced, so medications such as sulfonamides, carbamazepine, and lamotrigine as well. You've got some others which are the anti-epileptics, so like phenytoin, and all of those would also be kind of relevant. The clinical features, so you've got maculopapular vesicle, or bulla. The mucosa will be involved in this case, or can be involved, not necessarily all the time. You've got systemic features. This one's also Nikolsky positive. The important thing is the management is you need to admit, and it's kind of supportive management, but it's just to make sure it doesn't get too severe in terms of the disease. Then we've got staphylococcal scalded skin syndrome, which is due to staph exfoliative toxin, which can happen with Staph aureus, for example. The clinical feature would be more likely in children who have had a recent infection. And again, it's Nikolsky positive, and the management, because it's a Staph aureus, staph-related infection, you'll need some IV vancomycin.
So you see in the images how the skin is like gone off.
Just peeling off.
Yeah, it's like peeling off. So this is basically a red flag. So when you think about it from a clinical perspective, if you notice
I think we've lost Rapali.
Oh,
can you hear us?
I can hear you. Can you hear me?
Yeah, we've just
Okay.
lost you for a second.
Sorry about that. Can
No,
you see
that's
my
all
screen?
right. Yeah, but it's on the erythema nodosum
Yes.
slide. Yeah, okay. Oh, it's just because it cuts
Yeah,
you
it's the
off
next
mid-sentence when you're showing the picture.
Okay. So what I meant was clinically, if there's any rash where the skin's peeling off, or any condition where the skin is so damaged that it's peeling off, it's a red flag. So they need to come into hospital to see what's going on and what kind of skin condition it is.
Perfect. So erythema nodosum, the pathophysiology is autoimmune in nature, and it affects the subepidermal layer of the skin. The way it presents with it is part of other pathophysiology. Oh my goodness, pathologies, including sarcoidosis, is quite prominent in that. It can also be present in people with tuberculosis infections, gastrointestinal infections, IBD in general, and then it can be also medication induced. The clinical feature is that it's tender red nodules on the shins. So it can also present in pregnancy as well. That could be some relevant kind of information in the question stem, which would be pointing towards erythema nodosum. Erythema multiforme, it's related to herpes simplex virus, as well as Mycoplasma pneumonia. You've got these kind of symmetrical red raised rashes on the palms, which would be related to like a past infection or a current infection of those that are stated here.
Yeah, everything that's in bold is a buzzword, is something they'll give you in the question stem. So when you are doing these questions, look out for these words, and it'll be a hint to what the diagnosis is.
Cool. Dermatitis herpetiformis, again, autoimmune in nature. It's due to deposition of IgA in the dermis. It's very much associated with celiac disease. And the way it presents is that it's very itchy and vesicular type kind of rash. And it's mainly on the extensor surfaces. So you've got the elbows, the knees, and the buttock as well. The way it shows is like on the picture, it's very... It looks, for me, the way I kind of see it is that it looks a bit like a zoster infection, but you need to remember of where it would show up to be able to differentiate in terms of picture-wise. The investigations would be, again, a biopsy, and the management would be gluten-free diet in celiac disease patients, and you can also use dapsone if required, but otherwise it's a bit of supportive management. Next is pyoderma gangrenosum, very much neutrophilic related, like mediated process, dermatosis. It is quite rapidly growing, and it's following trivial trauma. I believe it's quite related to people with diabetes, if I'm not mistaken. They'll usually say, oh, the person's diabetic, they've had a trauma, and they've got this kind of lesion on the shin for some time. The way it shows up in terms of clinical features, it would be quite sudden in onset, small pustule, and then quite a painful ulcer. And then you can also have some systemic symptoms if it kind of progresses to a more important infection. The management would be, again, oral steroids, and then, if required, immunosuppressive medication such as like cyclosporin and infliximab. Actinic keratosis or solar keratosis, very much prevalent in middle-aged people. So it's related to UV light, so it's sun damage, and it can also be pre-malignant for some sort of oh my goodness, malignant.
For squamous cell carcinoma, it's pre-malignant. Because Clem can't talk today, so I'm sorry about that.
Yeah. So again, it's middle kind of age or elderly people who have been in the sun, exposed in the sun a lot. So people sometimes say like, oh, I used to work as a farmer and I've been kind of getting these for the past few years now. So very outdoorsy kind of people, more like fair-skinned people as well. They're going to be quite flat, well demarcated and dry, and they bleed easily. And a major buzzword is sandpaper-like appearance. They love to use that word to describe actinic keratosis. The management is cryotherapy, and then curettage or excision. And then if you need any topical treatment, it's more 5-fluorouracil salicylic acid as well that can help. Squamous cell carcinoma, so one of the skin cancers, so it's related to light, which will be very prominent in someone's history that they kind of sunbathe a lot or have been outside a lot of their lives. Clinical features will be keratinized or scaly, ulcerated or crusted. So that's a very characteristic presentation, the picture that's put there. They will be more present on the head and neck. They can also affect the ear, the nose. I mean, they can pretty much pop up anywhere, any areas that have been exposed to the sun quite a bit. And as Rapali wrote, it doesn't look very nice to look at.
It's just to differentiate. So if they give you pictures, squamous cell is the one that looks like horrible and yucky compared to basal cell. We'll get to that next.
Yeah,
So
it looks a bit
if
more
it
like
looks gross,
ulcery in this case, to be honest, in my like.
yeah.
Management, you need to send for a 2-week wait referral, which I believe they don't use the word 2-week wait anymore. I was told by a GP. They use the urgent wait referral or something like that because they can't meet the 2 weeks. So I think it's been kind of removed from. And then you could have surgical treatment to remove it, which could be just done under local anesthesia as well. Okay, so the next skin cancer would be the BCC, basal cell carcinoma, or also called rodent ulcer, again related to UV light exposure. You can have, it's usually slow and local invasion, so they can show up like this characteristic picture, which is a pearly dome-shaped with kind of rolled borders. I kind of see it as being like a donut shaped because it's got that central ulceration. And then you're going to have some new little vessels, or kind of prominent vessels, sorry, which are going to be the telangiectasia, which is going to be on the inside or in the middle, depending on the lesion. Again, you need to do a referral to dermatology, and if it's very extensive, then you need to do an urgent referral. If it's kind of in an awkward position, or it's related to the eye or anything like that, or it's quite significant in size. And again, you just do local excision normally. Melanoma, which is the nasty, nasty skin cancer that you don't want. The pathophysiology, again, is related to UV exposure. People who kind of use tanning beds a lot, and smoking is a risk factor as well. The way it presents is a pigmented lesion, which is quite irregular. It's going to be brownish, so like a mole. And it's going to have very blurred margins. It could arise from a mole that was originally there, and then it started changing in color, in size. The borders they used to be round, they've now become a lot more irregular. So in this case, maybe the darkest round spot on the left could be the original, and then it started spreading. That could be a possible example. Yeah, exactly there. So it's good to always kind of know for the patients to know what kind of moles they have, and to just always keep an eye if they haven't been checked off by a dermatologist or by a GP. Investigations, it's a 7-point checklist where you've got majors and minors. You need two major points, which is a change in size.
No, Clem, every major finding
Gives you
is
2
worth
points.
2 points. Yeah.
Oh, fine, sorry.
Yeah.
So change in size, irregular shape, irregular size, and then the minors would be more the diameter, which would be over 7 millimeters, inflammation, oozing, and then a change in sensation in that area. The management is an urgent referral again for suspected cancer if the score is more than 3 or more, or if it just looks quite suspicious. Then the management would be surgical, and then possible sentinel lymph node biopsy as well.
Just to add on, a clinical tip, when you see anybody with a rash or any sort of lesion, if you are sending them home, you draw around the rash so that they can keep an eye on. One, you tell them to take pictures, and a lot of times they do. They come in and they tell you, I've been taking pictures of this lesion or this rash, and then it's getting bigger, worse, whatever. And when you're sending them home, you advise them to continue taking pictures. And two, you draw around it. So you draw a border, and then if it is increasing in size, that's obviously concerning, and they need to come back in. So this is something I learned as an F2.
Yeah, especially in cellulitis. Sorry, I was zoning out. Especially cellulitis, that's something that could be useful, and then more also for the longer chronic skin conditions can be useful. So alopecia areata, it's a chronic inflammation of the hair follicles, and it causes a lot of hair loss. So it can be asymptomatic with like sort of well circumscribed, smooth patches, with short broken little hair, which are like very, very small hair. You can also have some pitting nail changes as well. The investigations would be skin scraping to kind of visualize what's underneath and what's going on under there. And then the bloods would be thyroid function tests, because hypothyroidism can cause some hair loss, full blood count, ferritin, and then systemic lupus erythematosus screen. The management, if hair is growing back, then there's no required treatment. Otherwise, you can try a trial of potent topical steroids, which would avoid the chronic inflammation and would allow the hair to grow fully to their normal length. And then you'd refer for dermatology if they require further management, which could be intralesional steroids or even immunotherapy, whether topical or oral.
So I have alopecia as well. and you have flares. So there was a time when I was in third grade and I had a patch on the back of my head, and then it settled. So the hair grew back. So there can be a bit of variability in terms of, is there a patch, is there no patch, is the hair still growing? And the buzzword for this is like exclamation mark hair. So if they do something called a hair pull test, where they're going to try to pull on your hair, and if a bunch of it comes out, then you've got alopecia essentially. And if it doesn't, that means that's good. That's your hair roots are really good. So that's just some tidbits. Not that relevant for your exam, but hopefully it'll help you remember it. There are other types of alopecia as well. So there is male pattern baldness. There is telogen effluvium, which is basically stress-related hair loss. But again, so those will be in your multiple choice as options, but this is the one that's most commonly tested. I will send another document that has more detailed dermatology explanations and different conditions. Those are my notes when I was studying dermatology. So you can read up more if you enjoy dermatology and would like to know more, but this is essentially most of the high yield stuff. Sorry, Clem, I went off track.
No, that's all right. And then the topics I hate the most, anything with little microorganisms or little insects. Head lice, which is also called Pediculosis capitis. It feeds on the blood of the scalp, so it's basically just lice. It's quite itchy. You can see the lice themselves or the eggs, which are going to be kind of stuck in place on a hair. And then you can also see, like I said, the lice on the scalp itself or on the hair. The management is, as a lot of people would know if you've ever had head lice as a kid, is you need to kind of shampoo with your hair with that shampoo that's going to kill them, and then use those really, really tough and tight combs to kind of remove all of the eggs and the lice. You need to also kind of insecticide. You need the insecticide, sorry, for the whole household, which is usually malathion, and then repeat 7 days later to make sure that if there's any eggs or anything that was missed, then you can remove that as well. Another kind of bug is scabies, and it's usually close, prolonged skin contact. So it's very common in kind of nursing homes and elder people or just people who live in quite close quarters. They're going to come in with very itchy rashes on the hands, interweb of the fingers, and it's going to also cause like little burrs in the finger webs, and they're just going to be saying it's very, very itchy and bothering them. And you can see the rash on the picture there. The management is, again, a topical insecticide, which you need to repeat after 7 days. You can use permethrin 5% dermal cream. You do need to treat the entire household and clean and wash all the linen quite at high temperatures to make sure that you kill off any of it. And then if it's quite an extensive infection and you need further input by dermatology, they would probably be giving you some oral ivermectin for further treatment.
Oh, that's it. Sorry, I think I
Perfect.
repeated the slide. Yeah.
No, that's all right.
Question?
Does anyone have any questions? I don't know if we have time for a few questions if anyone needs.
We all good? You can always ask me questions later on the WhatsApp group, or like reach out if you think it's like a weird question or whatever. And I would recommend, now that you've watched this, I'm going to send you the questionnaire, which I'm hoping you filled before watching this as well. But fill that out and then try to recall the things you've learned and if you've got time today, do the question banks today, because you're just going to consolidate all of this information. So that's it. It was a quick revision, 40 minutes. Well done, Clem.
Thank you.
Very rapid, very AKT. And if anyone has questions, reach out.
Thank you guys for showing up.
Oh, also, just before everyone leaves, is everyone okay with being recorded? Because it's going to go up on YouTube. None of your faces are visible. Nothing's visible. So you don't have to worry about anything like that.
Basically,
Lovely.
if you have an issue, just let us know and
Yeah, let us
Pali
know,
because
and
she's
then
gonna upload it.
yeah, we
I
can
think we've
sort out
got 2
something.
yeses, which is fine.
Yep. But yeah, thank you for joining, guys. We weren't expecting anyone to show up live.
No, we thought it was just gonna be a one-on-one.
Yeah. But yeah, hopefully it was helpful. And we'll see you tomorrow for ENT and ophthalmology. Bye.
Bye.